Welcome back, everyone. We're going to continue down the pediatric series with pediatric respiratory emergencies. With most of the disease processes we're going to discuss with pediatric patients, you will have seen, and we've discussed previously in the medical emergency section, usually with adult patients. What we're going to focus on with pediatric patients, though, are specific presentation differences or specific treatment differences that may be relevant for the pediatric patient, as well as refresh on some of the more common pediatric diseases that you're going to encounter. As far as respiratory emergencies in the pediatric patient, this is probably one of the most frequent medical complaints that you're going to respond to. Respiratory and failure and respiratory arrest will precede most pediatric cardiac arrest. So it's important that we assess respiratory function well and we understand that respiratory insufficiency is going to lead to cardiac arrest in those pediatric patients. And so early identification and treatment or intervention there is going to be critical. With respiratory arrest, distress, and failure, first determine the severity, right? Distress is compensated respiratory insufficiency. Respiratory failure is decompensated respiratory insufficiency. And respiratory arrest is cessation of respiratory effort. Keep the anatomic and physiologic respiratory differences in mind. Remember that for pediatric patients, they nearly double respiratory rate, and their tidal volume is not necessarily increased because of the physiologic makeup of their bodies, but their oxygen demand is nearly double that of their adult counterparts. So it takes a significant amount of work and effort to keep an oxygenated pediatric patient, and their respiratory rate indicates that. So make sure you're assessing appropriately for age-appropriate changes. As defined earlier, right, respiratory distress is that increased work of breathing, but it's compensatory, and that means that they're working to increase their work of breathing and increased rate, tidal volume. However, they're able to at least somewhat compensate. So maybe mild hypoxia, but significant work of breathing. And that effort of respiration is important to note because they can't keep that up forever. So they may deteriorate from respiratory distress into respiratory failure, which is when they can no longer compensate. And this is when we start seeing significant changes like hypoxia or carbon dioxide retention. And respiratory arrest is the cessation of that ventilatory effort. You can look here and determine in severity. Here's a table for reference on determining severity and can help indicate some of the urgency for transport. If you're transporting quickly, take a family member with you or a caregiver with you, bystanders, somebody who knows the patient and knows the patient's history, because you can gather that history en route. So some ominous signs, and we talked about the pediatric assessment triangle previously, but things like agitation, restlessness, confusion, those altered mental status signs are going to be really important. Skin color, things like central cyanosis and pallor. Respiratory rate, when we look at the progression of respiratory distress into respiratory failure, initially the patient will be tachypnic, and then they'll move to bradypnea, and this is a slower breathing, and this indicates that they're decompensating quickly, and they can move into that apnea phase quickly. So you need to make sure that you're vigilant and aware and hyper acutely aware, if you will, for these patients' respiratory rate and respiratory status, as well as heart rate. Tachycardia will subdue or will degrade into bradycardia as hypoxia becomes more prominent for these patients. Respiratory distress is the most common complaint that we see as far as respiratory natures. This is only typically requires supportive care, but your index of suspicion should remain high because with fatigue, respiratory distress can progress into respiratory failure. So reassess frequently. Give supplemental oxygen for hypoxic patients, right? Medications indication, the indication for oxygen is hypoxia. Treat your patients accordingly. If available or if at your certification level, establish IV and ECG monitoring is important. Every provider level should be monitoring the patient's airway. And then if you need to administer ventilatory support and back valve mask ventilation is failing, consider the use of things like supraglottic airways or intubation. For foreign body airway obstructions, little guys, your pediatric patients explore the world by putting things in their mouth. Their sense of taste is some of the first senses to fully develop in the human body. So their natural way to explore the world is to put things in their mouth and feel them and taste them and see what they are. This can lead to potential for Foreign body airway obstructions, right? For a mild obstruction, if they're awake, have increased work of breathing, but good color, they may have stridorous respirations, then let them try and expel or encourage them to cough if that's an age-appropriate intervention. For severe obstructions, they'll often present as cyanotic or even potentially unconscious. Babies explore the world with their mouth, so you can have all sorts of things in their mouth, not just food products. It can be things from the floor, things from any number of places. So just be vigilant and be aware. As far as removing a foreign body, in responsive infants, you're going to do 5 back slaps and then 5 chest thrusts for baby. Those back blows, and you should have practiced this in BLS class, but those back blows need to be of significant force. Just patting a back of a baby isn't going to help there. And then we rotate over to chest thrusts until either the item is expelled for a complete obstruction or baby becomes unresponsive, in which case we start CPR. Make sure if it's a foreign body airway obstruction induced cardiac arrest that you're at least intermittently evaluating for the object to be visible in the oral cavity to be removed. You can use the Heimlich maneuver in young children. You can position the patient supine if they become unresponsive and begin chest compressions, right? An unresponsive, in not breathing adequate patient is presumed to be in cardiac arrest until proven otherwise. Anaphylaxis is a potentially life-threatening allergic reaction. It's triggered by exposures to an antigen, right? And the onset of symptoms typically occur immediately. For your pediatric patients, the child may be unresponsive due to respiratory failure and shock, and primary survey will often reveal things like hives, swelling of the lips or oral mucosa, and or stridor and or wheezing. Treatment for anaphylaxis, an anaphylactic emergency, is multi-phased and should be rapid administration. If you suspect anaphylaxis, epinephrine should be first-line medication along with supplemental oxygenation and ventilation or ventilatory support. Fluid resuscitation and diphenhydramine if your certification level is appropriate for that, and you may also consider bronchodilators such as beta-2 agonists, such as things like albuterol, and you may consider Duoneb if your certification allows, again with the increased secretions that may occur with anaphylaxis. Croup is the viral infection of the upper airway. History will usually reveal several days of a cold symptom and a low-grade fever, and then they'll develop that croupy, barky sort of cough and may have stridorous sounds in respiratory during respiratory times and difficulty breathing. Initial management for these patients in the pediatric patient is just like we would talk about in croup in an adult. Position of comfort, right? Try not to agitate the child. If allowed by protocol in your certification level, you can consider things like IV dexamethasone or intramuscular dexamethasone. Nebulized epinephrine can occasionally be helpful with these patients. Again, certification bearing, and then assisted ventilations with bag valve mask may be necessary if they have ventilatory insufficiency. Epiglottitis is an inflammation of the epiglottis and the supraglottic tissues. The classic presentation is a sick appearing, right? So obtunded or staring off into space sort of appearance. So the child that's anxious, sitting in the sort of sniffing position, head elevated, nose kind of up in the air. Oftentimes they're leaning forward and drooling with an increased work of breathing. And pallor and cyanosis are common associated with epiglottitis. Symptoms progress really rapidly. You should inquire about immunizations and get the child to an appropriate hospital. Remember that when we're treating patients, we need part of our job is getting the patient to the most appropriate facility. It's not always, the most appropriate facility is not always the closest facility, not always the community hospital down the street. They may need to go to a pediatric center, particularly for the treatment of progressive infectious disease as well. So be prepared for bag valve mask ventilations for these patients and an ET tube. One note about the epiglottitis patient: if they're maintaining their airway by drooling and those secretions are leaving their mouth and they're maintaining their own airway patency, leave it alone. We don't want to go and dig around with suction catheters because the patient's drooling unless it's impeding their airway. So if the patient sits back and that becomes included, then you may be problematic there. But let the patient compensate if the patient's able to compensate and manage that airway on their own. Bacterial tracheitis is a bacterial infection of the subglottic airway area of the upper airway. Children typically present with cough, stridor, respiratory distress, and can be preceded by a viral infection, although that's not always known. Keep the patient calm and comfort as possible. Asthma is going to be the most common chronic childhood illness, and it's characterized by that sort of triad of presentation: the bronchospasm, mucus production, and airway inflammation. We treat accordingly based on that triad of presentations, and it's not uncommon for us to see increased rates of more severe asthma attacks in things like springtime when allergens are more prevalent, because that's one of the triggers. And then significant changes in weather, so first time it gets really cold for the year, or if the patients are exposed to other environmental factors like secondhand smoke. Clinical signs: frequent cough, wheezing, general signs of respiratory distress. Most patients are well managed at home with their asthma. And so when you see the patient, it's oftentimes because their at-home management isn't working. And so part of your assessment for these patients should be, are you prescribed an inhaler? Did you use your inhaler? It's also not uncommon for us to respond to schools because the patient's first day of school or first week of school and they didn't have their inhaler. Initial management for these patients: position of comfort, supplemental oxygen. All levels can administer that, right? Bronchodilators, if your certification allows. You can also consider IV dexamethasone. And you should be considered mucus inhibitors as well. So for these patients, remember that you've got airway swelling, bronchial constriction, and mucus production is that triad of symptoms for this disease process. Your beta-2 agonists like albuterol will help dilate the bronchioles. Your mucokinetics like Atrovent can help reduce the mucus production. And then you may consider volumetric expansion with the fluid transition that occurs or may be needed, or things like IV dexamethasone or steroid medications to help longer-term treatment. A note with steroids for my advanced level providers out there: there's often a discussion that really doesn't even warrant discussion that we shouldn't give steroids pre-hospital because the changes take 20-30 minutes to impact the patient. But the reality is, the sooner we can get that on board to the patient, the sooner they're going to experience relief. So it's not about what we see in the pre-hospital world as far as response to treatment. It's about getting that medication on board sooner so the patient gets relief sooner. So don't ever withhold a medication for the idea that, well, we're not going to see any difference. It's not about you. It's about your patient. And then progressive asthma response or asthma treatment may require things like epinephrine or even racemic epinephrine based on certification level. RSV is respiratory syncytial virus. It's common and contagious virus and presents as bronchiolitis and pneumonia in children. It's droplet transmitted, and indirect contact with contaminated hands or items can also transmit the virus. Early stages are basic sort of rhinitis or sinusitis sort of presentation: sneezing, runny nose, nasal congestion, cough, and then maybe a fever. Prevention, part of our responsibility for infectious disease is preventing that spread of infection. So make sure we're using personal protective equipment, including gloves and masks when necessary, and clean your vehicle after you transport the patient. Post-exposure treatment is going to be largely supportive. Bronchiolitis is an inflammation of the swelling and small airways and lower respiratory tract, mostly due to viral infection. It's highly contagious. Characteristic findings include things like a mild to moderate retractions, tachypnea, diffuse wheezing and crackles, and mild hypoxia. There is a danger of respiratory failure, particularly if your patients are presenting with any of these sort of following presentations. If they're excessively sleepy, you're seeing things like severe retractions, diminished breath sounds, or moderate to severe hypoxia. Remember that a silent chest is an ominous sign, and this is true for your asthmatic patients as well. So progression in airway sounds, when we talk about lower airway constriction sounds, so if we're talking about things like wheezing, you'll have loud wheezing early on, mostly during expiratory phases for respiratory progression. Then you'll move to inspiratory and expiratory wheezing. Then you'll move to kind of audible wheezing where it's really loud. I mean, you can hear the patient wheezing from kind of across the room. Then as the disease progresses and the airways further constrict, sounds get quiet, and that's when it gets ominous. You have to be able to move air to make extrapyramidal lung sounds, to make noise like wheezing. And as the patient's moving less and less air, those sounds become more and more quiet. And so if you move to auscultation of the chest and you're hearing little to no breath sounds, that means there's little to no air movement, and that's an ominous sign in your patient. Greatest risk for respiratory failure due to bronchiolitis or in the first months of life. Concomitant factors include things like prematurity, lung disease, congenital heart disease, and immunodeficiency. Management's going to be largely supportive, right? Position of comfort, supplemental oxygen, suction secretions if they're not being managed by the patient and potentially posing an airway hazard. If suctioning and oxygen administration fail, you can consider, based on your certification level, nebulized racemic epinephrine. And that should be given for severe respiratory distress patients in general. Constricted nature, epinephrine is a potent bronchodilator, and that can help alleviate some of that. We don't really want to go that as a first-line treatment because of the cardiovascular impacts that can have. But as far as late-stage or secondary, tertiary treatment is something worth considering. Again, if your certification allows. So understand what your scope of practice is based on your certification level and what your protocols allow and your med control physician allows, and move within those parameters. Decrease infecting, a disease infecting the lower airway and lung. This is pneumonia. Signs include usually rapid breathing, grunting, wheezing. It can be hypothermic or with a fever, and care is going to be largely supportive for these patients and getting them into a long-term care facility that can administer IV antibiotics or antiviral medications and treat accordingly. Pertussis is known as whooping cough, right? Highly contagious. Symptoms are similar to the common cold. Airway patency is going to be your key with this, and just supportive care predominantly. Cystic fibrosis is the genetic disease that affects the respiratory and digestive system. There's a chronic mucus production, and as well as accompanied by tachypnea, chest pain, crackles are all common. Supportive care, right? Administer supplemental oxygen as needed for the hypoxic patient. Bronchopulmonary dysplasia. This is a spectrum of lung conditions found in full-term and preterm neonates who require long periods of high concentration oxygen. These patients are commonly on and need ventilator support, and they'll be on at-home O2 most of the time. Remember your ABCs, right? If a patient's inadequately ventilate, then ventilate. If the patient is hypoxic, oxygenate. CPAP or BiPAP may be needed for these patients. Make sure that you have age-appropriate and age-specific equipment if you're using a CPAP on an infant or a child. Patients may also require intubation for higher-level providers.